But first tonight, we're talking about your health. Joining us is Dr. Taofeek Owonikoko, Executive Director of the University of Maryland Medical Center's Greenebaum Comprehensive Cancer Center and Professor of Oncology at the University of Maryland School of Medicine. Doctor, thank you so much for being with us. November is Lung Cancer Awareness Month, still the most deadly of cancers. How much of that is smoking?
Thank you so much for having me. Yes, November is the Lung Cancer Awareness Month. And lung cancer remains a deadly disease, one of the most common cancers worldwide, and the most lethal cancer for us here in the United States. It's still a major problem, and majority of the patients who would develop lung cancer would develop that on the background of prior risk of exposure to tobacco smoke. So that is still a major factor.
I read that of the people who have never smoked, the incidence is rising. Why would that be?
That is accurate. We now observe in the last decade or two that patients with lung cancer who never smoked constitute a significant proportion of the population of lung cancer patients. About 20% of patients here in the US will be diagnosed with lung cancer without any real exposure to tobacco use. And worldwide, in different parts of the world, that number could be anywhere between 30 and 40% of patients in Asia, for instance. Still an unknown in terms of what is really driving this increase in people who are never smokers developing lung cancer, but we are beginning to get some insights. Part of this could be exposure to particulate matter, in addition to other risk factors that we know could drive lung cancer development beyond tobacco, such as environmental exposure to radon, for instance.
And particulate matter, is that more of an occupational hazard, or it could be around the house too?
It could be both. But when you're thinking in general, we think about particulate matter in the environment, both occupational but also residential. There has been some studies done that show that when you have cooking around the house, for instance, there are some particulate matters that may be released from cooking. Oftentimes that is going to not hang around your house for that long. But for those who work in specific occupation where this could be in the atmosphere for a very long period of time, and they get exposed to it, this could be contributing to this risk factor. We're still waiting for research to really prove this, but there's some growing evidence that this could be contributing to this increased incidence of lung cancer in never smokers.
I did read that in the never smoker category, women are more likely to develop lung cancer than men. Is that the case?
That is true. Before we understood the molecular driver of lung cancer, the epidemiologic studies show that you're more likely to find women, people of Asian origin, and younger patients developing lung cancer when they've not had significant exposure to tobacco. Now, with our better understanding of molecular drivers of lung cancer, we now know that there are unique specific genetic changes within the cancer cells that tends to be more common in people who never smoked. And this group of diagnosis of lung cancer, what we call genetic alteration that drives the lung cancer, is much more common in women than in men, for instance. But you can find it in any patient of any gender.
Reminder viewers, if you have a question for the doctor, you can send us an email, livequestions@mpt.org. Let's turn to treatment a little bit, lots of different modalities. What's new on the treatment front?
The good news is for patients with lung cancer, we've now, in the last 20 years, we've made significant progress in all manners of treatment that we have for this disease. Starting from targeted therapy, now that we understand the molecular drivers of the disease, we now have agents that can be used that will target specific changes within the cancer cell. Oftentimes, these are pills that you take by mouth. And the use of these agents in the last 10, 15 years has actually reduced the death related to lung cancer diagnosis because they work really well, both in advanced stages as well as in early stages of the lung cancer. The other major advance is the use of immunotherapy. Immunotherapy is a drug that works with your immune system, unlike chemotherapy or targeted therapy that works directly on the cancer cells. Immunotherapy works with the immune cells in your body and wakes them up so that they recognize that there's something going wrong in the body in the form of cancer, and then the immune cells will then eliminate the cancer. The third area where we've made progress is the use of less invasive surgical techniques. Before, when someone with early stage lung cancer is going to go to surgery, it's usually a big surgery that they open the chest to get into the lungs. Now what we call video-assisted thoracoscopic surgery, where you use a pinhole surgery, is more or less the standard for majority of the patient. And the advantage of this is it carries less morbidity. Patients stay for shorter duration of time after surgery in the hospital, and there's less tissue damage, less pain, recovery is faster. And we know that the outcome is just as good as if you went through open thoracotomy.
Is there a category of lung cancer or a stage of lung cancer where you believe it can be cured?
Yes. Lung cancer is curable, just like majority of cancers when caught very early. So we call cancer curable when you can do everything you can, whether surgery, radiation, or medicine, that will make that cancer go away and never come back. And we know that for patients that are diagnosed with stages 1 and 2 and some stage 3 lung cancer patients, we actually could cure them. If you think of patients with stage 1 lung cancer, for instance, over 5 years, which is typically how long we follow before we say somebody does not need any more follow-up for that specific cancer, 70 to 80% of stage 1 lung cancer patients might be cured of their disease. If you wait until it is too late and you get diagnosed at stage 4, for instance, less than 20% of those patients may be alive at 5 years. So we know that diagnosing the cancer at very, very early stages is one sure way to cure it.
So that brings us to how do we catch it early? Is it symptomatic at that early stage?
So in the very early stages, when it is curable, oftentimes it is not symptomatic. So you have to make effort to find it. And the good news is we do have the tool to diagnose lung cancer very early, especially in those who are at very, very high risk of developing the lung cancer. And those are older patients from the age of 50 to 80 who smoked, especially if they smoked heavily, what we call pack years, meaning somebody smoking a pack of cigarettes daily for 20 years. That would be 20 pack years, for instance. And when did they last smoke? So if you smoked within the last 15 years, and you smoked about 20 pack years, and you are within that age range of 50 to 80, there is a tool that we can use, what we call lung health scan or low-dose CT scan, that can detect the cancer when it is still relatively small, asymptomatic, and curable.
How, if somebody's been a long-term smoker, how open are they to doing that test?
I think majority of patients are well informed. Part of the challenge is for them to be aware that there's a tool available to them to use to be diagnosed early. And across the state of Maryland, just like the rest of the country, we actually do have designated low-dose CT centers where you can go at the recommendation of your primary care physician or your pulmonologist or your oncologist if you have one at that point. It's informed decision so that you have to know what you're trying to do and what the outcome is going to be and what process you have to follow in order for that to happen.
Viewer question, Elizabeth wants to know, is lung cancer hereditary and what tests are available to determine that? So if it runs in somebody's family, should they automatically get tested, and is there maybe a different test?
So that is a very, very good question in terms of hereditary nature of lung cancer. The vast majority of lung cancer is not hereditary, but we've had reports of lung cancer running in some families, and in those families it tends to be a specific genetic alteration called EGFR that has been found in multiple generations of the same family. Unfortunately, because it is so rare, that is not something that we want to promote as a way to find lung cancer unless you truly have very strong family history, and then you can see the genetic counselor. Then they can do proper testing and proper discussion with you in terms of what tests to undergo in order to be diagnosed very early.
Interesting question. This is from Kevin. Is there a link between marijuana use and increased risk of lung cancer?
The short answer to that is we still don't know. The jury is out there. I think you can find data to support whichever side of the argument you want to take, but what we know is certain things travel together. When people use marijuana, they also are more likely to use tobacco. And then it becomes difficult to separate what is due to marijuana use and what is due to tobacco and what is due to the use of both together.
I think everybody who smokes at this point knows it's bad and they want to quit, but it's tough. They'll quit and relapse. I just have half a minute, couple sentences. What's your best advice for a long-term smoker who might be watching?
The best advice is to never have started. If you've started, to stop. And if you're struggling to stop, there's actually help along the way. There is the quit line that you can call. If you call our center, we can guide you to where to find resources that will help you be able to quit smoking.
And the best place to get started on a scan, if that's appropriate, also contact the Greenebaum.
Contact the Greenebaum Comprehensive Cancer Center, and we will set you up. Most importantly, discuss with your primary care physician.
Dr. Owonikoko, we appreciate your time. Thank you, sir.
Thank you so much for having me.
Your health segments are a co-production of Maryland Public Television and the University of Maryland Medical System.